Good morning. Welcome to the Cannabis and Pain Past, Present, and Future webinar. We're glad you're here. My name is Lisa Mighton. My colleague Tanya Hyde and I will be moderating the webinar today. We work with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD and Pain BC in collaboration with the Canadian Pain Coalition. It is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships. As mentioned, I'm Lisa and Tanya's here. We'll be moderating the webinar and handling the Q&A. And our presenter today is Dr. Mark Ware. Dr. Mark Ware is Associate Professor in Family Medicine and Anesthesia at McGill University. He is the Director of Clinical Research of the Alan Edwards Pain Management Unit at the McGill University Health Centre and Executive Director of the Canadian Consortium for the Investigation of Cannabinoids.
Go ahead and hand it over to you, Mark.
Great. Well, thank you very much for the introduction and a pleasant welcome to everyone who's joined in. I'm doing this webinar from Ottawa, and I gather that we're 3 hours behind or ahead of you, so it's an early morning start, and thank you for being with us. Thank you to the CIRPD for inviting me, and as was mentioned by Lisa and Tanya, the Q&A I'm sure is going to be extremely important. I can guarantee you that there are far more questions than answers. My goal in the next 45 minutes or so is to talk you through a very quick run through basically the fundamentals of cannabis and the rationale why and the evidence for its use in pain, such as it is. And throughout the presentation, I'll be trying to highlight where I think the important research questions are arising and what work is being done at the moment to try and respond to those. So without further ado, I'm going to begin with my disclosures. As the Executive Director, the Consortium has received grants, contracts, and funding from governments, from other agencies, and from industry, and we are a member of the UN NGO Committee with interest in scheduling cannabinoids at the UN level. And I have received funding and am receiving funding from one of the licensed producers for a clinical trial of vaporized cannabis in osteoarthritis, which is set to begin shortly. The objectives of this webinar are to, first of all, to appreciate the trajectory of the development of cannabis and therapeutics, where it's come from and where we think it's going, to look at current evidence for cannabinoids in pain management, to consider the limitations of that current research, both with respect to efficacy and safety, and looking at the use of cannabis both in the home and, where possible, in the workplace. And then to use this opportunity to think about the research opportunities that present themselves, and as well as the challenges in using this very novel and controversial class of drugs. I'll begin with two case studies. As a primary care physician working in a pain management unit, we're often faced with patients coming asking about cannabis, and these two real cases present some of the examples of the kinds of questions that we're often faced, and maybe these are familiar to you. The first patient was a 62-year-old woman who presented with chest pain in the anterior chest, secondary to repeated radiotherapy treatment for bilateral breast cancer. She'd had bilateral mastectomies and was treated with radiotherapy successfully, 5 years disease-free, but had persistent neuropathic pain of the anterior chest wall, which was not responsive to most of the conventional anti-neuropathic pain medications. She had tried a number of procedures and topical and oral medications, and presented asking whether cannabis, she'd heard about it. She said, should I try marijuana? She was never a previous user, had never used marijuana in the past, and was asking about its use for her condition. So this is one classical situation, a naive user asking about whether this is something that they should consider. The second example was a different case, a 42-year-old woman with body pain that had been undiagnosed for 20 years. She struggled with this. She was obese, had recently had a rheumatoid factor test positive, and was therefore given a diagnosis of rheumatoid arthritis, and had been using cannabis at a dose of about 3 grams per day for those 20 years, was not functioning, was at home, unemployed, and very poor physical condition, but wanted me to authorize her cannabis use for medical purposes, and wanted to be put into the legal medical marijuana program. So I I'm sure by now you're already thinking about responses to these two patients. You have questions that you'd like to know about their backgrounds. And so this sets up the kinds of discussions that we're faced with patients. Obviously, there are many others, but these two examples, I think, bookend the type of discussions that we're often being asked to have with our patients. So what do we need to know about cannabis and cannabinoids to begin having a dialogue with these patients? First of all, we have to learn how to pronounce cannabinoids. Lisa struggled with it. A lot of people do, but if you can get your lips around cannabinoids, you're already halfway there. We've just published in Clinical Pharmacology and Therapeutics what we call the cannabis curriculum, which summarized in this slide outlines, I think, what are the major issues that a practicing clinician or healthcare professional should have some kind of working knowledge of. The background and history of how we came to have a medical cannabis program, and it's useful to compare this with opioid drug development as a way of putting this into perspective. Understanding the botany of the plant, where the cannabinoids come from and why the herbal product appears to have such interesting properties for therapeutic purposes. The biology of our own endogenous cannabinoid system is important to understand the targets for these drugs. The way the drugs act in the body, the pharmacology is important, and the methods of administration, the different routes that can be used to administer cannabinoids. And then, of course, efficacy and safety are important to consider and review with patients. Being aware of the likelihood of and reality of cannabis abuse and misuse is critical in having these discussions. Being aware of local, legal, and federal considerations with respect to medical cannabis policy, and finally issues around communicating with patients around medical marijuana. There are some unique challenges in this discussion that I think are worth considering at the very end of this presentation. So without further ado, I'm going to use this framework as a guide to the rest of this presentation. The comparison with opioids is useful really rapidly to show that for a number of years, in fact going back to historical antiquity, people knew that opium was a source of analgesic medicine and was used for analgesic purposes, and it wasn't until the 1970s when we identified the opioid receptors and the discovery of endogenous ligands, the endorphins, and then subsequently, of course, issues with the use of opioids in pain, both cancer and non-cancer and other purposes, has begun to become an issue in the last decade or so. Cannabinoids follow a similar trajectory. The use of the drugs have been known for a long time to have some effects in certain pain conditions, but it wasn't until the 1990s that the endogenous ligands and the receptors were classified and identified, and subsequent to that there's been an accelerated pace of neuroscience research in understanding just what these drugs and what these compounds are doing in our bodies, and how they can be a target for drug therapy. So we're about 20 to 30 years behind the opioid story, and I think this is important to realize that wherever we are today, I think we can hope that if research continues and if the dialogue continues, we should be having very different discussions 10 to 20 years from now. The reality is we're faced with issues today, and so the rest of this presentation is really going to focus on what we know now. The botany of the plant is interesting, and I'll focus predominantly on the production by the cannabis plant of the major active ingredients, tetrahydrocannabinol, or THC, and cannabidiol, CBD. What the publication by a group out of University of Toronto and Saskatoon found some very interesting differences in two main types of cannabis. One is the cannabis that we all know as the marijuana, which is the drug on the street, and the drug which is of currently most interest in terms of therapeutic potential. But intriguingly, they studied the hemp version of cannabis, which is an identical sort of sister variety of cannabis that appears to not have any psychoactive properties. And the reason for this is that the two plants, or the two strains, express very different levels of the enzymes responsible for converting the substrates of the cannabinoids into either THC or CBD. That is to say that cannabidiol is expressed exclusively by the hemp variety of cannabis, and tetrahydrocannabinol, THC, is expressed by the drug type of cannabis. And the distribution on this schematic shows the enzyme expression in the two varieties. Very different enzymes, but other than that, the plants are very similar in terms of their makeup and the expression of their gene products. The cannabinoids come from the surface of the plant. They're not found in the leaf or the stem or the stalk or the roots. They're expressed on the surface of the flowering female in small hairs that are expressed right at the time of peak flowering. And on the top of those little hairs or trichomes are these tiny bubbles, which are where the cannabinoids are synthesized and expressed on the surface of the plant. And this is important because accessing these active ingredients therefore doesn't require using the bulk of the plant material, but using the constituents of these tiny trichomes on the surface of the flower. And that's important when we consider alternatives in delivery of cannabinoids from a plant source. The cannabis plant expresses a huge number of these compounds. The enzymes that we described are responsible for the production of the major cannabinoids, but there is an enormous family of lesser cannabinoids, including cannabinol, cannabichromine, cannabigerol, and so on. There are also a large number of terpene compounds, which are what give cannabis its unique smell, and to a great extent, the unique odor of cannabis is due to these compounds, not the cannabinoids themselves. The plant is also known to contain antioxidants in the form of flavonoids, and then in the seeds, hemp seed oil, for instance, is a very well-known source of omega-3 fatty acids. So the plant has unique properties in terms of its expression of these compounds, and most of the cannabinoids are modifications of a basic terpene structure, which you can see at the bottom of this slide, and modifications by the enzymes give rise to the different family of compounds. We tend to focus nowadays on the major cannabinoids, THC and CBD. In terms of future research, there's a tremendous explosion in understanding, identifying, and characterizing the other cannabinoid constituents. But from the point of view of medical use today, the licensed producers who are producing cannabis under regulation with Health Canada are standardizing the product on the basis of THC and CBD. And this graph shows the distribution of the different cannabinoids compounds in different varieties. So you can see that the major varieties available on the market today are in the range of 15 to 20% THC at the bottom of the graph on the x-axis, with very little CBD or no CBD. And there are some companies that are producing plants which on the y-axis show 9% CBD, and some are even reporting higher levels with very little THC. And then you have a number of varieties which are almost exactly 50-50. And this is because of those genetic expressions. The plants are either homozygous for the synthase for THC or for CBD, or they have a 50-50 mix if they're heterozygotes. So plants can either produce naturally THC or CBD or a 50-50 mixture of both. And these are the strains that are now available. What's fascinating is the number of different strains that have between 15 and 20% THC are reported by patients to have different effects on different symptoms. We know nothing about the validity of these claims or whether they're in fact responsible, whether these differences are due to differences in cannabinoid levels. It looks as if the THC levels are fairly similar in most of them, but what may be interesting is the possibility that the differences occur in those other terpenes and flavonoid compounds, and that it's the overall profile of cannabinoids, terpenes, and flavonoids that give rise to the individual strain differences. This is hypothetical and has yet to be tested in any clinical research. Turning to the human brain for a moment, the target for THC in particular and the major psychoactive cannabinoids is the CB1 receptor, the cannabinoid 1 receptor discovered in the late 1980s. And it's now known to be extremely widely expressed throughout the human brain, in particular in the central brain regions responsible for memory, learning, mood, appetite, movements, and also importantly in controlling pain and muscle control. And it's this target that gives rise to the potential therapeutic use of cannabis. Also, importantly, the potential abuse of the drug as its involvement in addiction, reward pathways, and so on. And it's the ubiquity of the receptor that makes using this as a therapy so challenging. It's very difficult to only isolate the cannabinoid receptors that are involved in pain or movement and avoid targeting receptors which are involved in memory or in psychoactive effects. So trying to target or specify cannabinoid receptors for therapeutic purposes and avoid the unwanted psychoactive properties is very challenging using a broad CB1 receptor agonist. It's important to note that cannabinoid receptors are not found around the brainstem regions which control respiration, and this differentiates them distinctly from the opioids, which, of course, in high doses, because of their clustering around the respiratory drive centers, gives rise to the likelihood of respiratory suppression in overdose. This is not a known risk factor for high doses of cannabinoids for this reason. The actual way in which these receptors function in the central nervous system is known to be through a presynaptic suppression of excitation or inhibition of the presynaptic neuron. And to summarize, the CB1 receptors are located here, as you can see on this diagram, on the presynaptic terminal, and are activated only when a neurotransmitter is released, but activates the postsynaptic neuron, at which point the endogenous cannabinoids are synthesized, released, and diffused back to bind to the CB1 receptor. On activation, the CB1 receptor then suppresses release of the neurotransmitter, which effectively closes the loop, and the neurotransmitter stops being released. And this natural feedback mechanism is thought to be the reason why we have so many cannabinoid receptors, and that this function is occurring endogenously all the time in controlling and ensuring that neurotransmission occurs in a smooth and well-regulated process. Of course, this also gives rise to the potential therapeutic effect of targeting the CB1 receptor as being able to suppress abnormal firing in the instances of epilepsy, of neuropathic pain, and so on. So by exogenously administering a cannabinoid, one can potentially suppress these abnormal presynaptic firings and therefore potentially control abnormal nerve transmission. You may also see in the bottom corner of this figure a CB2 receptor. I won't spend too much time on this, but this receptor is not known to be activated by the major cannabinoids, but does appear to play a role in neuroinflammation, and this is an area of tremendous interest as we start to realize the role of microglia and astrocytes in certain pain conditions, especially neuropathic pain and in the spinal cord. It's important to note that with the discovery of the receptors and with the development of pharmaceutical ligands, both antagonists and agonists, in the animal models of neuropathic pain, of diabetic neuropathic pain, chemotherapy-induced pain, HIV neuropathy, CB1 agonists have been shown to be analgesic in all of these conditions. And if we were just looking at the animal model as a reason to consider studying cannabinoids in humans, this would be a very, very strong argument. And in fact, these studies have all concluded with the claim that cannabinoids show potential analgesic properties in these models. And it's not just neuropathic pain, but also other models of central neuropathic pain, spinal cord injury, MS, cancer pain models, the local effects in osteoarthritis, visceral pain, and so on. So from an animal model literature, the use of cannabinoids in these models appear to suggest that there's potential therapeutic value. The issue, of course, is translating this information into human and clinical use. This has been done already. There are commercially available prescription cannabinoids. THC is available as an oral capsule called dronabinol. This was approved in the mid-1980s, interestingly, before we knew how the drug worked or what the endogenous cannabinoid system was doing. It was approved for anti-emesis in chemotherapy-induced nausea and vomiting, and approved as an appetite stimulant in patients with HIV/AIDS-associated anorexia and wasting. Nabilone, a synthetic CB1 agonist discovered in the 1970s, was also approved in the 80s as an antiemetic for chemotherapy-induced nausea and vomiting. More recently, nabiximols, a combination of plant-derived THC and cannabidiol, CBD, in the form of an oromucosal spray, was approved in Canada for the treatment of multiple sclerosis-associated neuropathic pain, spasticity, and then more recently for advanced cancer pain. It's the only one of the cannabinoids that actually has a formal indication as an analgesic. And it contains these two compounds, but also, as it's a plant-derived mixture, it contains a small quantity of the other plant-derived compounds that we were mentioning earlier. The fourth category of prescription cannabinoids, in inverted commas, is of course herbal cannabis, which is available, as you will all be aware, as a special access mechanism through the medical marijuana regulations in Canada and increasingly in other countries, Holland, Israel, and in some states in the US there are also medical cannabis programs. But it's important to point out that in none of these countries or jurisdictions has cannabis actually received a formal approval or an indication as a therapy. Turning to the pharmacology of the drugs then, in humans, it's clear that when you give cannabinoids orally, they have a very low plasma THC level, and this is specifically looking at THC, and for most of the rest of this session we'll be talking about THC. But it's important to realize that the levels appear at about an hour at their peak effect, whether they're given orally or sublingually or as an oropharyngeal spray or a buccal spray. So essentially, the oral or buccal administration results in a very slow onset, about 1 to 2 hours for peak effect, with effects that can go on and are felt by the patients for 4 to 6 hours and sometimes even longer. But the plasma levels don't go much above 5 nanograms per milliliter in the plasma. This is in strong contradiction to inhaled cannabinoids, and if you look at the graphs on the right-hand side of this slide, this compares cannabis that's been used either by smoking or by vaporization, and you can see plasma levels of THC here reaching up to 100 or more nanograms per ml, so considerably higher plasma levels, which decay very rapidly, and by 2 to 3 hours, the levels have reached very small quantities, and in fact the effect is very short-lived in the human. So oral versus inhaled administration have very different pharmacological profiles. The reason why vaporization has been so interesting is because what this does is it heats the surface of the plant to the point where those tiny trichomes, those little balls of cannabinoids, are liberated in the form of a vapor, but it doesn't destroy or burn the underlying plant material. And this is important because the plant material is really the source of the toxins that we associate with smoking. So if we can strip off those cannabinoids using a vaporizing technique, we can potentially administer the active ingredients without burning the plant and without exposing people to the potential harmful ingredients and the byproducts of combustion. And this is also receiving increasing interest, and in fact with the development of electronic cigarettes and portable vaporizers, this is an area that deserves considerably more attention as a way of developing therapeutic delivery of cannabinoids. And in fact, in Israel, a portable vaporizer device has now been developed and is undergoing clinical trials. These graphs show the fact that in a small sample of neuropathic pain patients, a very small quantity of herbal cannabis, 15 milligrams, which is almost a pinch of plant material, when put into this vaporizer in specific unit dose inhalers containing 19% THC, is able to deliver cannabinoids to the effect that these patients in this uncontrolled study had some analgesic effect, as you can see on the left. Pain in 20 minutes dropped down from about 8 to 4 and then returned when the drug was wearing off. And you can see here the plasma levels attained in this study in the middle graph between 20 to 50 nanograms per ml. So comparing that to the oral administration and the inhaled route in those other studies that I was showing you, this appears to be a window of potential therapeutic effect. And at this dose, and in fact in almost perfect parallel to a study that I published in the CMHA in 2010, which also showed that 9.5% THC in 25 milligram doses using a pipe, and this was a smoked study, achieved almost identical plasma THC levels of between 40 and 50 nanograms per ml. And these patients reported analgesia but did not report significant euphoric or psychoactive effects. So the potential, and again, looking forward at research down the road, is this a therapeutic window where we can deliver cannabinoids to the brain, selectively get analgesia, but avoid some of the central effects that we want to enable patients to continue functioning. And I think these small single-dose studies are a window to trying to identify adequate dosing potential and regimen. Looking at efficacy, in the interest of time, I'm going to summarize in two recent studies. One was done by our colleague Mary Lynch in Dalhousie and her friend Fiona Campbell, who published a systematic review in 2011 looking at clinical trials of cannabinoids for non-cancer pain, and they found 18 studies, 15 of which were in neuropathy, 2 in mixed and 1 in other pain conditions, evaluating a number of different cannabinoids, which we've mentioned already, including one synthetic azulemic acid, which has never been further studied. This was going back into the early 1990s. In none of those studies were any serious adverse events reported. And the author, Mary, and I recently published, this is in February of this year, published an updated systematic review looking at an additional 11 trials Also looking at a range of cannabinoids, nabilone, nabiximols, smoked cannabis or vaporized cannabis, and a Phi inhibitor from Pfizer, which was intending to block the enzymes that metabolize endogenous cannabinoids. That trial was negative, and Pfizer subsequently stopped their program of Phi inhibition. But 7 of these studies were positive, and we saw some serious adverse events out of these trials, 3 on the extract, 2 on nabiximols, and 1 on nabilone. The conclusions, and I think the takeaway message from the clinical trial literature, and this is subject to considerable debate, but the reality is that all of the studies that have been done with cannabinoids to date, with the exception of a few of the studies on the oral cannabinoids and some of the mixtures, have been short studies, about 2 to 4 weeks in duration, small numbers of 40 to 60 patients, and the effect sizes would be best described as modest, reductions of about 0.7 on a 10 centimeter VAS scale in pain management. That's the classical tool we use to measure effects. But the conclusion in our review was that the safety profile was reasonable, the analgesic effect was modest, but that these provided a reasonable option in the treatment of chronic non-cancer pain. The proviso, of course, is that we don't know much about the longer-term use of these drugs and the longer-term safety. But this data has been sufficient for the Canadian Pain Society to include cannabinoids as a third-line possibility for patients who've tried the standard treatments for neuropathic pain. And this currently is probably the only place where cannabinoids fit in any kind of pharmacological guidance documents or guidelines. And it's important to point out that these are not drugs that are being considered as first-line agents for neuropathic pain or for any other condition, but that they remain a potential option once all other approaches have been tried or considered and have failed. There are synthetic approaches, and it's important to point out that there are drug companies trying to work on other mechanisms to target the cannabinoid system that don't involve the use of plant material or inhaling. I mentioned the Phi inhibitor from Pfizer. AstraZeneca tried to make a CB1 agonist that stayed out of the central nervous system but only worked peripherally. That appears to have also been shelved. Glaxo has been looking at a CB2 agonist, but that did not work in a third molar extraction pain study, and so I don't believe that that has also received any further attention as an analgesic. And blocking CB1 as a potential treatment for obesity, the natural extension of the known fact that cannabinoids stimulate appetite. If you block cannabinoid receptors, you could suppress appetite, and this drug actually went through several phase 3 clinical trials, was approved in Europe as a weight loss drug, and was being investigated for cessation of smoking, but was withdrawn because the patients on this drug began to express high levels of depression and suicidal ideation. The drug was withdrawn. So blocking CB1 on a global scale does not appear to be a safe option. And this slide demonstrates some of the work that's being done in neuroimaging studies, which are beginning to explore the role of cannabinoids in analgesia. And without going into too much detail, what the study effectively showed was that part of the analgesic response to cannabinoids is not so much due to the direct analgesic effect or reduction of pain intensity, but actually a change in the perception of pain by the patient, mediated by the amygdala, which changes the unpleasantness of the pain. So the patients say, and I've had this experience in the clinic, patients reporting that the pain is still there, but it doesn't bother them as much, and that they're able to continue functioning and able to continue to move despite the pain. And this study bears out the possible mechanisms for that within the central nervous system, and this is also undergoing further exploration. Turning to safety of cannabinoids, much of what we know about the safety of cannabis comes from studies of the recreational use of the drug. Obviously, marijuana has been used recreationally in certainly Western society since the 1960s, and there have been a number of long-term epidemiological studies exploring the possible adverse effects of this drug. These, of course, are in mostly healthy recreational users who may be using the drug in a different way and obviously for a different purpose. But Nora Volkow, who runs the National Institute on Drug Abuse, abuse, published in the New England Journal last August 2014, a summary of the adverse health effects of marijuana. And again, in recreational use, she broke it down into short-term effects and long-term effects. The short-term effects are well known: impaired memory, difficulty in retaining facts, impaired motor coordination with interference with driving skills, judgment changes, and high doses, especially in naive users, paranoia and psychosis. And in long-term effects, this is mostly restricted to patients who begin using cannabis early in life, in adolescence or earlier. And in these situations, it's clear that there are a higher rate of addiction that may change brain development. There have been associations with poor outcomes educationally and functionally, as well as impairment in cognitive function and reduction in overall life satisfaction and achievement. Outside of the early adolescent use and the long-term effects of use starting early in life, the most important effects of cannabis use in adult populations appear to be on the lung, with bronchitis being well associated with cannabis smoking, and it's clear that there's an association with psychosis, which appears to affect patients people with a predisposition to the development of psychosis, as it doesn't appear that cannabis by itself can create a psychosis in somebody who doesn't have either a genetic or some other predisposition to developing the disorder. We reviewed the systematic effects of medical cannabis in 2008 and published a study in the CMAJ looking at clinical trials of cannabinoids, specifically identifying the safety factors. And we found that overall there was a higher association with adverse effects in the cannabinoid users compared to those using the placebo, and that these effects were mostly mild to moderate. The data won't be shown on this slide, but it's clear that the adverse effect profile of prescription cannabinoids, and this was mainly looking at nabiximols, nabilone, and dronabinol, were dizziness, drowsiness, dry mouth, and effects that were very compatible and consistent with other medications that we use routinely in chronic pain patients. The likelihood of serious adverse effects was not found to be very high, so the drug appears to be reasonably well tolerated from a safety point of view. We have not yet seen data looking at smoked cannabis or vaporized cannabis with respect to the reports of adverse effects, although this data is forthcoming. It's important to point out then, based on what we know of recreational use and some of the early medical use studies, that cannabinoids are contraindicated in patients with a history or a family history of psychosis, should be very cautiously approached in patients with unstable heart disease, either arrhythmias or ischemic heart disease, and certainly avoided in women who are pregnant or breastfeeding. Precautions are advised in patients who have histories of dependence, legal issues, criminal charges where the motivations for access to legal cannabis may be different. The possibility of seeing a patient who's asking about cannabis also provides a very good opportunity to screen for cannabis use disorder. And this is probably the major concern for physicians who aren't clear whether the patient who's asking about marijuana is looking for it for medical purposes or in fact is really choosing or trying to find access to the drug for recreational purposes. Cannabis use disorder deserves special attention. It's recently been reported in the DSM-5, and this table summarizes the major flags that you should look for if you suspect cannabis use disorder in a patient with chronic pain, insisting on the document for dried cannabis instead of trying other more appropriate therapies, daily use and spending unproductive time on finding cannabis, poor outcomes in terms of school, work, or social functioning, other substance abuse history, risk factors for cannabis use disorder, including youth, concurrent mood and anxiety disorders, difficulty stopping or reducing the use of cannabis, and the presence of withdrawal symptoms if they do try and stop use. And then finally, if there are family members or friends who are concerned about cannabis use, these are also signals that the patient may not be controlling the use of cannabis effectively and may, in all these situations, may require referral to a treatment dependency program. That this abuse of cannabinoids is not unique to herbal cannabis. Of course, all of the drugs that target the CB1 receptor could potentially be abused, and in fact, nabiximols has been shown in the appropriate dosages to cause effects like being stoned and having impairments. So we have to think about cannabinoids as a drug class overall. To my knowledge, and we've reported in a couple of papers, that we haven't been able to show that the oral prescription cannabinoids have any street value. They don't seem to show up in prisons and in other areas where abused drugs show up. So this doesn't appear to be a major concern for the prescription cannabinoids at this time. But of course, herbal cannabis is so available that if they really want a cannabinoid effect, they know other ways to get it. One of the suggestions prior to this presentation was to consider cannabis use in the workplace, and one of the major issues there is side stream smoke and the effects on health professionals who are exposed to people smoking cannabis or vaporizing. There's a lot of interest in trying to set up policies in hospitals so that patients who have a legitimate use of cannabis can use it in their institutions. And this very intriguing study out of Johns Hopkins showed that, and this intriguing experimental design, they built a perspex room and put volunteers into the room, half of whom wearing the blue hats were smoking cannabis, the other half were not smoking cannabis, and were tested after the exposure to huge amounts of cannabis smoke. You can see how densely smoke-filled the room was. They were tested for the effects of cannabis in their urine and in psychological testing. And indeed, it was shown under these extreme conditions that cannabis use exposed in secondhand format was able to produce positive urine testing and able to show psychoactive effects. But it's important to point out that when they opened the windows and ventilated this room properly, those effects disappeared. So if you happen to be in a very small, tight room with a lot of smoke, then the risks of exposure appear to be significant. If you're in a well-ventilated, well-aired room and the doses are much smaller, then that risk appears to be much, much lower. And you can see the plasma levels of THC, the urine levels of the carboxy metabolite in those people exposed to cannabis smoke under these conditions, especially when the room was unventilated. You can see the lower levels of the carboxy metabolite in the room once it was ventilated go way below detectable levels in standard urine drug testing. Switching quickly to medical cannabis access, most people will now be familiar with the fact that the marijuana for medical purposes regulations took full effect in April 2014, and the mechanism of access for patients is through this medical document. This is from Health Canada's website, which is essentially a prescription. It contains the patient's name, the health professional's name and license and so on. But interestingly, it also asks for the daily quantity of dried marijuana in grams per day and a period of use. And this, I think, is where many physicians start to run into difficulties. They don't know what amount of cannabis is appropriate. There are no known guidelines in terms of what a ceiling dose or a watchful dose should be. But what's interesting about this approach, and this is unique to this recent regulatory change, is that you can shorten the duration of use so that patients can try cannabis for a period of a few weeks or months, and then on returning to see the clinician, the effects can be evaluated and the prescription can be discontinued if the drug's not being found to be effective. The CMPA has weighed in on cannabis and essentially insists that physicians should be familiar with the program, should know the regulations and policies of the local colleges, which are coming out almost on a monthly basis from different provinces, that they should only sign documents once they have necessary clinical knowledge to engage in a meaningful consent discussion with the patient. And I think that is the fundamental issue. And when we come back to communication at the end, I think this is where clinicians need to feel comfortable having these discussions if they're going to embark on authorizing cannabis for patients, and that they should be aware and make the patient aware of the lack of information available, and this should be documented in the chart and so on. So for almost standard advice for prescribing any medications, knowledge of risks and benefits, and a clear, informed discussion with the patient. We've published we've reported on some possible checklists for physicians and health professionals interested in screening patients for cannabis use, and this slide very rapidly shows some of the things that we should be looking for. Obviously, the symptom of interest, the underlying diagnosis, the treatments, pharmacological and non-pharmacological, a checklist for potential contraindications, looking at other substance use, documenting the cannabis use dose, mode of administration, the existence or prior trials with other prescription cannabinoids, which should always be considered before prescribing herbal cannabis, what the patient feels it's doing for them, a social history, a good physical examination, and then an assessment, a diagnosis, and a treatment plan should be developed, establishing what it is that the drug is going to be used for and what will be considered as a determinant of success or failure. And again, this is just good clinical practice, recommending follow-up. These patients should be seen and followed by patients who know them and who are going to see them again, and not by somebody who's only seeing them once and authorizing cannabis and then never seeing them again. I think that practice should be abhorred. And we recommend that cannabis dose should be tried, measured, and quantified. In closing, some of the important issues around the possible access to legal cannabis has given rise to some intriguing data from, in particular, the US, where different states have authorized medical cannabis at different times. And this intriguing study, observational study coming out of the US in the late summer of 2014, showed that those states where cannabis programs had been implemented actually showed reductions in opioid or analgesic overdose mortality. So it was hypothesized that patients were using cannabis instead of opioids. This improvement remained present even after adjusting for the presence of prescription drug monitoring programs, strict regulation of cannabinoid, of opioid prescribers and so on. So this is an intriguing finding and certainly points to the need for us to take a strong public health approach if we're going to establish cannabis as a medicine, that we should be tracking its effects on the population at large. Finally, communication issues. Cannabis is a street drug with a number of different names. We have to learn to recognize these. If you don't know what wax and shatter are, then post a question and I'll try and answer that. But these are some of the terms that are now being used for derivatives and extracts of cannabis. Patients and the drug are very highly stigmatized. There's an enormous social and cultural movement around cannabis. It has a strong smell, and for this and many other reasons, physicians are very much aware of the cultural issues around cannabis use, and the patients themselves often feel, if they come and approach a physician about this topic, that they are being seen as cannabis users or pot users, and that this can result in stigmatization. And this finding has been reported in a number of studies, especially coming out of BC. Developing a treatment agreement, setting goals, exploring alternative delivery systems, and having a very good relationship with the patient are all critical for the success of using any cannabinoid in a therapeutic context. Finally, in Quebec, we've just launched a registry where patients will be tracked over a 4-year period who are using cannabis for medical purposes with respect to adverse events and also with respect to some outcomes in terms of pain, other symptoms, and functionality. And this comes about because of a requirement from the Quebec College that patients should only be given access to cannabis within the context of a research paradigm, as they consider it an experimental drug. So hopefully, by learning from patients who are authorized to use cannabis, we can improve our evidence base, specifically with respect to long-term safety, but also start to get some ideas about how much cannabis people are using, what different THC CBD strains they seem to prefer, and whether there's any indication that different levels of cannabinoids are associated with different conditions and symptom responses. There are a number of places and areas where professionals can get additional information. We've taken a very fast and very high-level look at the story in the last 45 minutes, but these links give you some access to other societies, other associations that are trying to take a serious and credible look at the potential therapeutic value of cannabinoids, and I invite you to visit these websites for further information. I have to acknowledge that I've received funding from a number of foundations, networks, and organizations that have funded my research, and I'm very grateful for that support, as it's enabled us to continue to try and walk what we think is a very delicate, fine line between cannabis use and abuse, and to try to allow physicians and educate clinicians about the discussion about cannabis with patients, so that when we return to our 2 patients at the beginning, we now feel that we have some tools with which to approach the discussion and to improve the effectiveness of the clinical encounter. So with that, I'm going to close, and I'm happy to invite questions and comments. Thank you.
All right, thank you very much, Mark. That was a really great presentation, very informative. I feel like I'm going to need to review those slides a few more times.
Thank you. I realized that there was a
back.
lot of material in a short space of time, and I apologize for that. I know I'm going to be criticized for having covered things very quickly, but I wanted to provide a very broad strokes look at the story and really stimulate interest for people to look into these in more detail.
No, I think it's wonderful, actually, and we will be providing both a recording for people to review again later, as well as the slides for people to review. So there will be options for people to come back and review the information over time. So I think that's great. Let's see. We do have a couple of questions. Since you were just talking about it, there was questions about what is wax and what is shatter. Yeah.
Yeah. So wax and shatter are terms that are being used for developing extracts of cannabis, and I pointed to the trichomes, the source of the cannabinoids on the plant material. Those can be taken off the plant in the form of vapor, but they can also be taken off in soluble form. If the plant is taken either shaken and the trichomes fall off once it's dried, they can be compacted, and hashish is essentially just a compacted resin, all those dried trichomes compacted together. If that hashish is taken and dissolved in a solvent like butane or naphtha or alcohol, and then the solvent is driven off, you can end up with extremely high potency cannabinoid extracts. And it's allegedly reported that these concentrates, and it becomes like a waxy substance, like a candle wax, a soft candle wax after you've been burning a candle, or shatter, which is actually hard and a very thin sheet of hard, crackable substance, which reportedly can contain THC levels of up to 70%. So extremely high THC levels, and very small amounts of this placed into a pipe or into a device for inhaling, those, once they're heated and combusted, give rise to a very rapid, very intense THC effect. And this is now common, or not common, but it's being used and abused in states in the U.S. where these extracts are allowed. And it's something of great concern because it really is a very high potency, very rapid onset cannabinoid effect, which I think probably has an even higher risk of abuse than does herbal cannabis in its smoke form.
One of the questions that we have here is about how the use of cannabis impacts on mood and motivation, and if it does the brain return to normal functioning when use stops, and how long does it take for the brain to return to normal functioning once cannabis is no longer being used?
It's a very good question, and again, most of the work that's been done on this has been done in recreational users, so we don't really know the long-term effects on cognition in medical users whose disorders may also have, and other medications may also have, cognitive effects. But in recreational users, it's somewhat controversial, but I think the balance of evidence suggests that it's clear that the drug has effects on mood, cognition, memory, and so on in the short term, but that after a period of abstinence of around a month or so, it appears as though those functions return back to the level of an age-matched cohort. So if you've been a heavy cannabis user for several years, if you are able to stop and discontinue the drug for a period of months, that cognitive function returns more or less back to normal. Now, there are specific neurocognitive testing that can be done that suggest residual effects, so it's not clear that that's a given, but it does appear that the effects for the most part are cognitive effects are for the most part associated with ongoing persistent use rather than a permanent effect if somebody stops using the drug.
All right, and then we had a couple of questions that were generally around the topic of dosage and determining dosage, particularly if you're not necessarily doing the pill format, but more of the herbal format.
Yeah. So the College of Family Physicians of Canada reviewed the literature last year and produced a preliminary guidance document that on looking closely at the literature, found that you can actually have medical effects and analgesic effects in particular at very low doses. And in the absence of specific dosing guidance, I think that the most appropriate way to recommend any herbal cannabis approach, especially inhaled route, is to use very, very small quantities. And as I showed you, 15 to 25 milligrams have been used in some small clinical studies. These are single tiny doses using an inhaled route, which, when we're talking about grams of cannabis per day, here we're talking about 15 to 30 milligrams of cannabis, a fraction of the amount that's possible to authorize. So there are two ways of approaching it. One is the amount of cannabis should be kept as low as possible, the number of grams per day as low as possible. But secondly, the THC level can also be adjusted, and patients can be authorized under the program at the moment to have access to cannabis that contains low levels of THC. And currently, the highest level of THC that's actually been studied in clinical trials is 9.4%. So there's been a suggestion from the college that you should really be considering cannabis authorizations of less than 9.4% for patients who are trying to use this as an analgesic to avoid the psychoactivity that may be associated with higher levels. Now, that's to say that the data exists for those conditions and for neuropathic pain using those kinds of cannabis preparations. We simply do not have any data on cannabis with higher levels of THC other than that one small study from Israel with a 19% THC. We have no other data on the safety and efficacy of cannabis in inhaled form using THC levels of higher than 9.4%. So keeping the total amount low and the THC level low are probably the most the loose but the most sensible guidance that we can provide at this time.
We have a couple of questions related to migraine and headache. Questions such as, is there an indication for cannabis in treating migraine and other headache disorders, and whether certain strains are known to be more effective?
So, well, I'll remind the listeners that there is no indication for herbal cannabis in any disorder at this time. Obviously, the prescription medications we talked about, their indications, but for herbal and vaporized cannabis, there is no indication, period. So that applies for migraines. So migraines have been reported, and William Osler described cannabis as being a treatment for migraine 100 years ago. But that's never been studied in clinical trials. We have no trial literature to suggest it. We can only go on patient self-report. Other headache disorders as well, chronic daily headaches, cluster headaches. There may be a few case reports circulating out there, and I don't want to go on record as citing them, but really that's probably the best level of evidence that exists for these conditions. It's astonishing to me that given that it's been claimed that cannabis is effective for migraine for over 100 years, that there hasn't been a single clinical trial to explore that, even using prescription cannabinoids. So unfortunately, there's a tremendous dearth of clinical information on that topic.
All right, and then someone asking, are there any guidelines being developed in regards to occupational health and safety, like contraindications for certain types of jobs, or research looking at return to work as a result of use?
Yeah, that's a very, very good question and a very pertinent one. I'm aware of a patchwork of policy initiatives that are taking place in various institutions across the country. I'm not aware of any that have actually formally come up with policies that have, that I can refer to in black and white. I think it's a discussion that's happening across the country. Certainly in health, in the workplace, and in health institutions. As far as it goes with respect to occupational health, I don't know that. I think there are restrictions in some industries about urine testing and the need to have clean urines when you're doing certain jobs, and certainly avoiding any psychoactive substance if you're operating heavy machinery. But I'm not aware of specific guidance around medical marijuana. I think it's an issue that tends to come up when patients show up to work saying that they have a medical marijuana authorization and that they're fine to do whatever they're doing. And I think this leaves employers and insurers in a very difficult bind. I don't believe that there's yet been any consensus in how to approach this topic, but it's very, very important. And in answer to the question about functionality, I mentioned that the studies that have been done to date have been short and relatively small. There are very few, if any, studies that demonstrate long-term cannabis use of any kind, any cannabinoid, being associated with improvements in function. I think that's a critical need for us to be able to move forward.
All right, very good. And then we have another question related to opioids versus cannabinoids. So, given the adverse effects of opioid use, addiction, impairment, and etc., which seem far more severe than cannabinoid, why does the medical community choose to exhaust use of opioid before attempting cannabinoid for pain management?
Yeah, that's a very good question. I don't necessarily know that the medical community is unanimous in saying that opioids should be considered before cannabinoids. I think given recent concerns about opioids and long-term safety there, I think physicians are starting to pull away from opioids a little bit. There haven't been many head-to-head studies comparing the two together, and it's theoretically true that cannabinoids have a different safety profile and a somewhat better safety profile than opioids. But of course, we've had opioids in prescription form and in clinical use for a great deal longer than we've had cannabinoids, so we simply have more data. I think this is where the public health approach has to come in, and we have to be tracking the use of these drugs in the population, and specifically in medical populations, to see if prospectively we can demonstrate that the adverse event profile is different or better with cannabinoids compared to opioids. I suspect that the resistance, if any, is to do with the fact that we simply cannot say with some certainty that the side effect profile of cannabinoids in medical use is much better than it is for opioids, and it'll take long-term safety studies to demonstrate that, whether they have to be head-to-head or whether they're just well-designed adverse event monitoring pharmacovigilance projects. But it was clear from the opioid story that opioids became available and were prescribed on a fairly wide basis before we discovered that there were associations with harm and the possible diversion and mortality associated with them. And that triggered a response to pull back on opioid prescribing and implementation of guidelines. I would think it very wise to begin, if cannabinoids are starting to get used in clinical practice in any form, prescription or herbal, that early monitoring of adverse effects should be implemented. And this is one of the major reasons why the Quebec registry was so well received. That early detection of these issues would prevent us waiting until we see problems showing up in the morgues or on the roads, so that we're tracking this prospectively.
All right, and then one question that is related to the Quebec registry is, should we not move towards a Quebec registry system on a larger scale in order to learn post-market effects?
That's a very good question, and I've been promoting the rationale for tracking prospectively patients using cannabis for many years. It's always struck me as a shame that we've had legal medical cannabis in Canada since 2001, 2002, when patients could access cannabis from a standard quality controlled supplier. It was only one back then. Of course, now there are 15, 25 different producers, but patients have been able to access cannabis legally, and thousands of them, for 15 years. We've learned nothing from tracking those patients about how much they use, when they use it, and what they use. So I think it's for me, it's always been a problem that we haven't tried to track this more prospectively. I think that the Quebec registry is one way to do it, and I certainly welcome any attempts to collaborate and to set up similar registries anywhere else. We've had a number of expressions of interest from the US, from some European states, to collaborate and use a similar registry model. Of course, in many places it will be a voluntary approach. Patients would have to consent and track it, but all the patients that I've seen and that I've known that use medical cannabis have often said, listen, study me, use me, I'm happy to be part of research. So I think the patients would engage in this willingly.
How effective are cannabinoids in forms like alcohol tincture and food products like olive oil and butter? Is anything known about that?
I'm afraid not. That's one of the gaps, and it's in part because this has kind of been a cottage industry, if you like, that's set up to develop these compounds, but also that the Health Canada regulations as they are now do not allow the Health the licensed producers to produce any standardized extracts or derivatives. So we simply don't have access to these materials in a form that can be put into clinical trials. It's certainly anecdotally true that patients find these effective and have switched from using them inhaled forms to using them in these forms of extracts and in teas and tinctures and butters and so on. But unfortunately, there's no clinical data on which to base clinical judgments at this time.
Thank you very much. And I think that we will close it there. Thank you so much, everybody, for joining us.